So you probably continue to wonder why we talk about diabetes at cardiology rounds, but I'm sure that most of you know that if you're dealing with cardiology patients, many of them are diabetic. And so over the last 20-some years, Professor Matt Riddle and I have had quite a nice collaboration. I think we've been in 6 trials together. One was relatively local, which Earl Hirsch and we took place in, and I don't know if Kevin is here, but Kevin had a role in that trial as well. So, and Matt is now the editor of Diabetes Care, which is by far the most impactful diabetes journal. He went to undergraduate school at Yale, did his medical school at Harvard, then did white suit training in Chicago at Rush, and did endocrine fellowship there, and then he came here a number of years ago and was here for a couple of years working with RHW. That's Robert Williams, for those of you who don't know the initials, and John Glomset, working on some very basic science issues related to atherosclerosis. So it's wonderful to have Matt come and talk to us. It's always wonderful to just be able to introduce a friend, and that's certainly what Matt is. So Matt.
Well, thank you very much, Jeff. It's a kind introduction. The little time ago that I was here was 1971 to 73. That was quite a long time ago, but they were 2 important years in my life, and I really enjoyed my time here. Part of what I did was to work with Russ Ross in his laboratory, so I had some cardiology connection already back then. But since then, I'm a card-carrying endocrinologist, and it's been my pleasure to work with Jeff and others in a number of big cardiovascular outcome trials. So I've learned a lot from Jeff about epidemiology and cardiology trial design, and I've learned a lot from my cardiologic colleagues. So I make it a point to say that because what I'm going to try to do today is to give you a sense of what's going on inside the head of my endocrine diabetes colleagues over some controversial interpretive issues that have to do with the treatment of patients with diabetes for their cardiovascular risk and for their cardiovascular disease. It's an ongoing story with new drugs, new therapies entering the mainstream, which always stirs things up. And so I'm just going to be telling you where I stand, at least on some of the issues. So this is my home institution just to the south with our snow-capped peak outside. That's Mount Hood instead of Mount Rainier, and my dualities. So here are the clinical questions that I want to talk a little bit about. The first is the controversy about what should be the hemoglobin A1C targets for glycemic control for treatment in primary care of patients with diabetes. And in addition to that, and really to clarify how the endocrine community sees that particular issue, I'm going to remind you of some things you know and about epidemiologic studies and some of the interventional trials, and maybe give you some things you haven't known or thought about up to now in relation to those things. And then I'm going to give you my big picture on how I believe diabetes ought to be treated as a public health problem, a big picture which involves the span of the natural history. And just to give you the reason I think it's useful to think of it that way, the epidemiologists at the CDC a few years back estimated that a person born in the United States at the turn of the last century, in the year 2000, has a 1 in 3 lifetime chance of developing diabetes. So it's not actually an unusual disease. It's something that everybody has direct contact with. So controversy. I put this together for a less formal kind of presentation a few years back, and I really like it. So there's there's all kinds of conflicts in the political world, and none of these are from an American venue. These are other international political encounters. I like the one where the one gentleman in the paneled box is throttling the other one with his bare hands. And I have to say that in medical circles we're somewhat more genteel, I'm happy to report. So the controversy about hemoglobin A1C goals for treatment was stirred up a bit about a year ago when in the Annals of Internal Medicine a group from the American College of Physicians published a statement with these main points to it. The first was that, as everybody agrees and starts off every statement with, we have to personalize treatment of everything for everybody. So there was no content to that one. But they also said that we really shouldn't be trying to get hemoglobin A1C below 7%. Most people should have higher targets than that. And if the hemoglobin A1C by accident drops below 7%, then you should back off on therapy. And for patients who are older and have a short life expectancy or even not older but have a serious illness, you can just stop measuring hemoglobin A1C and just not worry about it at all. And this puts some of my colleagues and me to some extent into a fit of apoplexy, because we've been trying all our lives to try to improve glucose control and prevent retinopathy and kidney failure and so on. So here's a little epidemiologic background. This is where some of the belief comes from that underlies the argument that we shouldn't be treating hemoglobin A1C below 7%. This is an epidemiologic analysis of a big clinical database, a lot of patients. And what it shows is a U-shaped relationship between the risk of mortality and the hemoglobin A1C level. And it's on the left, it's patients with type 2 diabetes on oral agents and insulin taking patients on the right. And the U-shaped curve shows an increase of risk when the A1C drops below somewhere around 7.5. Now, this is an epidemiologic study, and there are perils to interpreting such studies, and among them are illustrated are in the next two slides that I'm going to show, this and the next one, which shows cross-sectional data from the NHANES study, the national survey that gathers data on diabetes and related disorders. So in an unselected, broad representative population, the relationship for patients with diabetes between A1C and mortality is not U-shaped. It is linear, and it goes up as the hemoglobin A1C goes up. And if the A1C is below 6.5, it's the lowest. That's the top part. The lower part is the relationship for people not known to have diabetes, the ones who are not being treated for glucose lowering purposes. And they do have a U-shaped curve. So what happens when a person gets ill and is on the way to dying from some serious illness is that they don't eat very well, their glucose drops, they go into a semi-starvation state, and the hemoglobin A1C drops. So partly it's a marker of illness to have a dropping A1C, whether you have diabetes or not. And here's a larger study of the same kind from a similar database, the cross-sectional US database, showing that in people without diabetes, there is a U-shaped relationship. That is a higher mortality when the A1C gets below 7% or so, or especially when it's very low. So part of the epidemiologic analysis that underlies the argument that you shouldn't try to get glucose control close to normal is an artifact of illness. This is from the ACCORD study, which Dr. Prostfield and I had a lot to do with. And it's an analysis, an epidemiologic analysis, trying to understand the relationship between intensive glucose control and the 20%, 22% increased mortality that was seen that led to this early cessation of the trial after about 3 years. And what it shows here is a separate spline plots for the intensive group and the standard treatment group, who were trying to keep A1C below between 7 and 8%. And the U-shaped curve applies to the standard treatment group, but not to the intensive treatment group. So if you have intensive treatment and you get below 7%, you're in great shape in terms of mortality risk. it's the people who tried but could not get below 7% who had the increased mortality in the intensive arm, and I'll come back to that later. So I and a number of other people wrote in Diabetes Care a response to the ACP's statement, basically saying, let's look at the whole data set, both the whole epidemiologic data set and the interventional trial results, and try to really personalize treatment according to where the patient fits in to the information that we have about risks. I want to add one further introductory comment before jumping into the epidemiology, though, and that is that the complications of diabetes are both microvascular and cardiovascular. That is, eye, nerve, and kidney diseases are thought of, complications of diabetes are thought of as related to microvascular disease, capillary or arterial or disease to a great extent. And they are recognizable early because we have markers for them. We can look in the eye and see the blood vessels. We can measure proteinuria. So cardiovascular complications you can't recognize early on. They are developing, but you don't see them easily. You all are getting better and better methods, but it's still kind of late in the game that you begin to see clinical effects of cardiovascular diseases. So there's a time difference in the appearance of these complications. So this is, I showed this to my endocrine colleagues just to scare them. These are blood vessels, of course. This is early arterial intimal and intimal medial thickening changes. It takes a while to get this. It doesn't happen in a few days. It takes years. And these are the advanced lesions, which really are scary, actually. And I think the arteriosclerotic, the sclerotic as opposed to the atheromatous component of diabetic vascular disease is underrated. I'm sure that some of you are studying it in sophisticated ways that I don't understand. But it underlies some of the long-term risk that we're dealing with here in diabetes. So, lessons from epidemiology here. So, the first thing is that the average hemoglobin A1C is a good predictor of the risk of all the complications. And this is from the DCCT type 1 diabetes study, showing that as the A1C goes up, the average A1C observed during the 6.5 years of this study, the risk of eye, nerve, and kidney disease goes up. So the level of glucose matters, and also the time of exposure to it matters. And this is an epidemiologic study of retinopathy. Two of them actually, one from Wisconsin, one from Australia, done a long time ago, shows that quite a few people have retinopathy at the time of diagnosis. It develops rapidly enough that often undetected diabetes has already caused retinopathy by the time the diagnosis is made. It also shows that even back then, the Australians were making the diagnosis in a more timely way than we were in the US. So time matters for retinopathy. Time also matters for nephropathy. This is proteinuria as a factor of duration of diabetes in the PIMA population, another famous epidemiologic data set. And within the first 5 years, you begin to see increases of proteinuria after diagnosis of diabetes. And this is the famous Framingham study, Joslin cohort, showing a greater than twofold increase of cardiovascular risk in people with diabetes, more so in women than in men, actually. But here, the curves begin to separate a little later, not in the first few years of diabetes, but the main separation is after 10 years of duration of diabetes. So the time factor is there too, but it's also a little delayed. So the bottom line here, both the degree of hyperglycemia and the time of exposure matter to the complications, and the microvascular complications become evident sooner than the cardiovascular ones. So all that's kind of straightforward, but you have to keep that in mind when you look at the intervention trials. So because of this epidemiology, back in the late 1970s and early 80s, two big trials were started. The DCCT was a type 1 intervention trial to try to improve glucose control to prevent complications. That was started in 1982, I think it was. And UK PDS was a type 2 intervention trial in the UK, and that was started in 1977. The first of these reported was the DCCT in 1993, after an average 6.5 year follow-up. and it showed a dramatic reduction of eye nerve and kidney disease. The main endpoint was the retinopathy, easy to measure. 50% reduction resulting from a 2% A1C reduction over a 6.5-year period. It really answered the question about the glucose hypothesis. Yeah, it really does make a difference whether you have hyperglycemia, and you can reverse that with treatment. However, in that period of time, there were enough events to assess cardiovascular outcomes. But the DCCT lives on in the form of the EDIC, epidemiologic follow-up, and it's a small population, less than 1,500 patients, but they've been meticulously followed for up to 30 years now. And so this is a report on cardiovascular outcomes at the 17-year mark on average. Very small numbers of events, but there's a difference emerging here. 42% lower rate of any cardiovascular event, a broad composite, and this is standard 3-point MACE, a 57% reduction. Pretty big reductions, actually. Small numbers, but promising. And this analysis has been repeated at the 27-year follow-up mark. And the quantitative extent of the reduction is a little less. It's 30 and 32%, but it's still very highly significant. And it looks like it will continue over time, even though the intensive treatment stopped more than 20 years ago. Now, this is mortality in DCCT EDIC, and it shows that the curves are now separating. It took quite a while. It took about 15 years before the curves started separating in the desired direction. But as time, this is the 17-year follow-up data. I think, no, this is 26-year follow-up data. But the curves look like they're continuing to separate. So there's a long-term effect. The DCCT investigators now have among them some of the best statisticians in the metabolic world. So John Lakeen and his colleagues at Georgetown. And they have been trying to work out statistically what the mechanism of action of this legacy effect is by so-called mediation analysis. And they've been publishing a series of papers. Their most recent effort is in Press and Diabetes Care now, and Herzl Gerstein and I are writing a commentary on it. So it's all fresh in my head. But this is the published data that's out in the public domain already. And what they found is that there's a really strong correlation between hemoglobin A1C as a marker of glucose control and the cardiovascular outcomes in DCCT. You really don't have to invoke any other predictor. It's by far the most powerful one. And they also have now begun to tease out the relationship between hemoglobin A1C and its indirect value, its value as an indirect marker of tissue injury, reflected by high pulse rate, that would be neuropathy, systolic hypertension, that would be aortic stiffness, estimated glomerular filtration rate, and that would be nephropathy. And they find that each of these incrementally is part of the hemoglobin A1C associated statistical effect, and that the contribution to the A1C effect over the whole period of analysis increases over time. So they are identifying the mechanisms by which short-term hyperglycemic exposure or short-term euglycemic control translates to later cardiovascular risk. They're getting there in showing this. It's a small study, but it's a 30-year follow-up, and there aren't a lot of studies like that. So this is now type 2 diabetes. And this is the UKPDS, a much less tight design, not such a good epidemiologic data collection following it, but in the 10 years of the randomized treatment, intensive versus non-intensive glucose control, there was a 25% reduction of retinopathy and the other microvascular complications that went with a 1% reduction of hemoglobin A1C. So perfectly matching up quantitatively with the DCCT results. So presumably it's the same in type 1 and type 2. The only cardiovascular endpoint that was frequent enough to even come close to being analyzable was myocardial infarction, and it didn't make the 0.05 cut point, but it was a 16% favorable reduction. The long-term follow-up of the UKPDS, much less efficiently done, but it appears to show the same thing as with the DCCT, which is that the all-cause mortality curves, the cardiovascular mortality curves, the cardiovascular event curves are separating now. But it takes 20 or 30 years of follow-up to to show that. What it did show that it's affected treatment and the belief systems of all diabetologists everywhere is that metformin had a very powerful effect on cardiovascular risk in the UKPDS type 2 population within the 10-year frame of follow-up, and these are the curves that show that from the original UKPDS report. This study is the main reason that metformin is thought of as the foundational therapy for protection in diabetes. So the lessons from these studies: glucose lowering for microvascular disease has a favorable effect within 5 to 10 years, including symptomatic effects as in neuropathy and sometimes vision impairment with retinopathy. But glucose lowering reduces cardiovascular events only after 10 years and often even longer than that. So what about the more recent trials that you all are much more familiar with, I'm sure? Those are the trials that were done after the so-called failure of the DCCT and the UKPDS to show cardiovascular benefit with short-term randomized comparison of better versus less good glucose control. So these are ACCORD, the Veterans Affairs Diabetes Trial, the ADVANCE trial, and I'm putting ORIGIN in this category even though it wasn't a glucose lowering trial. So very briefly, ACCORD, the VADT, and ADVANCE recruited patients who had about 10 years duration of diabetes, longer duration. They all had high cardiovascular risk. They were selected for high cardiovascular risk, and they were given aggressive glucose control versus less aggressive glucose control as the intervention with cardiovascular endpoints, follow-up of between 3 and 6 years. And they didn't show any cardiovascular lowering. This is a pooled analysis, which I think actually, it's not on the slide, but I think it included the UKPDS cohort in this too. And there are other pooled analyses that have the same results. Overall, no cardiovascular benefit. Overall, no cardiovascular risk. And that was kind of disappointing to all of us. But I think the lesson from this, oh, sorry, one other thing. And this is the ACCORD. This is the 22% increased total mortality that led to the early cessation of the trial. And notice where the curves are separating. It's about, it's after 2 years. And that was the point of the trial at which mealtime rapid-acting insulin was introduced for many of the intensive treatment patients. And so far as I have a hypothesis as to what underlies it, it was that it's more likely to be due to prandial insulin therapy than any other single, with or without hypoglycemia as part of it. But we really don't know the mechanism. So what about the lessons that we take home from those short-term intervention trials in high-risk patients? Short-term glucose lowering does not decrease cardiovascular events in people who have established structural cardiovascular disease. And sometimes it can cause harm, and we don't really know why, and that makes everybody very nervous. And the other lesson, stated more metaphorically, is that you really can't get the horse back in the barn after it's out. So you don't reduce cardiovascular risk with glucose lowering in people who have structural atheromatous or atherosclerotic disease. Now, safety concerns with insulin. I have to get into this because there are people who firmly believe that insulin is a plague. It shouldn't be used. There's one British expert who shall go unnamed who said, "I wouldn't give insulin to my dog." His argument lies in evidence from epidemiologic studies that there's an association between insulin use and blood levels of insulin and cardiovascular death. That it causes hypoglycemia, and that hypoglycemia correlates with risk of bad events, and the association of cancer epidemiologically with insulin resistance, and therefore the need for high doses of insulin. And despite the fact that the better epidemiologic studies do not support this contention, there continue to be papers like these ones that are making this contention. And in one of these published reports, there was a call for a big randomized study to answer the question. Ironically, 2 years before 2014, when that was published, there was published the results of the Origin trial, which was a big randomized trial that Professor Probstfield and I had something to do with, which it was a big and a well-done trial. Salim Youssef's group from Population Health Research in Hamilton, Ontario led it. There were more than 12,000 patients studied globally with an average follow-up of about 5 years, maximum follow-up of about 7 years, so quite a lot of observation. In a very heterogeneous population, a lot of careful data collection, not very aggressive clinical management, so it was not too different from clinical practice conditions. And the risk of cardiovascular events was unchanged, no benefit, no harm. It was powered for superiority, but it was no effect, no harm, no benefit. All-cause mortality was unaffected. Cancer risk, either new cancer or cancer death, unaffected entirely. It's a totally null trial. So if you want evidence that at least this kind of insulin, basal insulin using glargine, is safe, there it is. You're not going to get better evidence than this. This is great safety evidence, in my opinion. There was actually a benefit in the slowing of progression from impaired glucose tolerance to overt diabetes. These were people with very early diabetes, and some of them didn't even have diabetes. They all had high cardiovascular risk, but anyway, the beta cell looks like it might have been protected by the insulin therapy. And the other thing I want to show you from Origin is the fact that under the conditions of the study, which were not really very different from clinical, sort of properly managed clinical practice in terms of frequency of follow-up, every 4-month follow-up, not a lot of phone calls and so on. It's possible to have really good glucose control. The average glucose control in the 85% of the population enrolled who had previous diagnosis of diabetes with an average duration of diabetes of 5 years. The A1C was averaged 6.5 at the beginning, and at the end of the study it averaged 6.5. So it was maintained for up to 7 years with either a basal insulin-based regimen, insulin first, everything else second, or a standard oral agent-based regimen, starting with either metformin or with a sulfonylurea, and then adding a second oral agent, and then adding a third oral agent. And this was not done with modern drugs either, or expensive ones. This was done in the standard arm. The typical treatment was metformin, glimepiride, and maybe a low dose of pioglitazone. So this is done with generic drugs, basically. So you can get glucose control in tough, high cardiovascular risk patients without harming them. There was more hypoglycemia in the insulin arm, but it didn't affect mortality or cardiovascular events at all. So my response to those repeated publications saying you should never use insulin is, here's a trial that says you can use insulin if you think it's the right thing to do. So moving on to the next step here. These are the more recent trials done, the third round of intervention trials, using new agents, not trying to use glucose-lowering agents in a very high-risk population to see whether there's a cardiovascular benefit, but using new treatments in a high-risk population to see if there's another way other than glucose-lowering alone to improve outcomes. And you're very familiar with this literature, I feel sure. I'm sure you've had multiple grand rounds on the SGLT blockers as an intervention for patients with diabetes who have high cardiovascular risk. And then the leader in SUSTAIN-6 are 2 GLP-1 receptor agonist trials. These are the first 3 of a whole pack of trials which are sequentially being reported out, including another trial that Dr. Postfield and I have worked on together, which is the REWIND trial, which is Lilly's dulaglutide long-acting GLP-1 receptor agonist. It'll be presented at the ADA meeting in June. So these are 3 representative trials of a whole group that are being reported out. And these are done in even longer duration patients with extremely high cardiovascular risk. They were selected for having already proof of structural cardiovascular disease in most cases. They're short-term studies, 3 years roughly on average. They were not mainly glucose-lowering trials. They were drug benefit trials due to mechanisms that were not solely based on glucose lowering. And as you know, the results are really very good. This is EMPA-REG, empagliflozin SGLT2 inhibitor with a renal effect that has a natriuretic effect and very good beneficial effect on heart failure, hospitalization, or death, and on total cardiovascular mortality, which is what's shown here. 38% reduction in cardiovascular mortality with the curve separating very early on. So a short-term, rapidly seen effect, which certainly does not have to do with reversing vascular occlusion or narrowing, but has everything to do with improving cardiovascular dynamics by other mechanisms, probably mainly renal, although there are some other hypotheses. And in this and other trials of the SGLT blockers, there is in patients who already have albuminuria a renal protective effect too, of similar degree. That is like a 30% reduction in progression of renal disease in those who already have established albuminuria. And that is a very favorable thing too, because we don't have very good treatments for slowing the progression of renal disease in diabetes. So these drugs are wonderful in this respect, and they're under intense study. I'm sure you've got trials. I'm sure there are people in this room doing some of these trials. You must be doing that. You probably know more about these drugs than I do. This is LEADER. This is a GLP-1 receptor agonist, and it shows a somewhat more modest but still clear-cut reduction in cardiovascular mortality with this once-daily, relatively long-acting GLP-1 receptor agonist, a 22% cardiovascular mortality reduction. Here the curves are separating out about a year out, and the belief, my belief anyway, is that the mechanism here is multifactorial. That is, there's some glucose lowering, there's some blood pressure lowering, there is some beneficial effect on renal dynamics. There may be direct tissue effects, although they haven't been very easy to tease out so far. So all that is good, and it gives you all something to help for treating the patients who come to you who have diabetes, who have a lot of cardiovascular disease. And I'm sure that at least a third of the patients who show up in your cardiac clinics have diabetes. Maybe it's 50%. It's a high proportion. And we haven't had much to offer them in the past, but this is very promising. Now here's where I want to plunge off into speculation. Rather than convincing myself that I know exactly where this is all going, I'm going to tell you where I think we don't know where this is going to end up. These are the questions about this particular class of drugs, the most interesting of the new drugs. First of all, will they have cardiac and renal benefits in people who don't have diabetes? And we don't really know the answer to that. The studies are underway, and we will know. There are reasons to believe that there will be some effect on sodium clearance and therefore total body sodium load, and therefore the stress applied to a weakened myocardium. But I believe it will be attenuated compared to the diabetic population. And the reason I think that is that SGLT2 is overexpressed in the presence of diabetes, probably due to continued glucose hypertubular glucose exposure due to hyperglycemia and increased filtration. And in addition to that, the more hyperglycemia, the more glucose appearing in the proximal tubule, the more obligatory sodium retention. So this is why patients with type 2 diabetes have long been known to have somewhere in the range of a 10 to 20% excess total body sodium content ordinarily, even without any heart disease. So I think that in theory, at least, the effect in non-diabetic people should be less than it is in diabetes, blocking this mechanism. Well, the second question is, can they reduce cardiovascular risk when cardiovascular function is normal? And again, we don't know the answer to that, but the subgroup analyses from EMPA-REG and other studies suggest that the cardiovascular benefit is more related to helping a failing heart than it is to any other mechanism. It's not alleviating ischemic mechanisms or arrhythmias, as far as we know. It's mainly about pump failure. So I'm guessing that people who have totally normal hearts will get only modest benefits of various kinds, microvascular and cardiovascular benefits from the drugs. But this needs to be defined, and we really need to have better markers, and here's where you and your colleagues are going to help us by showing us exactly how we can use natriuretic peptide measurements or some other marker of cardiac function to identify the high risk versus the low risk patients in terms of heart failure, and the high benefit versus less benefit patients with regard to using these drugs to prevent that. Third question, can we reduce renal injury when there's no albuminuria? And again, we don't know the answer yet, but Declare and Credence, two studies, are in the process of being reported out now. We're going to know the answer. I think my belief is that there will be only a weak protective effect for renal function in the absence of existing albuminuria, and I do not understand why. There are very smart nephrologists who think they have good theories, and we'll know pretty soon. But right now, we don't. But putting this together, I think that the main use for this class of drugs, empagliflozin and all the others like it, is going to be in people who do have diabetes, who do have albuminuria, and who have demonstrable presence of heart failure, of at least decreased myocardial reserve. And these other subgroups are still hypothetical candidates. And for that reason, I would say not every person with long-duration diabetes should be put on these drugs, both because they're costly and they have some side effects, and because we don't know the long-term safety. So what about the safety issues? So that's the last two questions. The first one, the risk of ketoacidosis. When you give a patient who has relatively impaired insulin secretion capacity, either because they have long-duration type 2 diabetes or they have type 1 diabetes. And in the broad population of type 2 diabetes, which is being widely prescribed this class of drugs right now, about 10% of them actually have type 1 diabetes. They're insulin deficient. And there are many reports of ketoacidosis, which is not recognized and diagnosed and treated early on in this setting during treatment with this class of drugs, because the ketoacidosis occurs when the blood sugar is not very elevated. When there's only 150 or 200 milligram per deciliter glucose, which is what the patients are used to seeing all the time, and yet you can have serious ketoacidosis, which can be fatal. There haven't been a lot of fatalities yet so far, but there will be, I think. And so the next question is, can we use these drugs to protect against nephropathy in patients with type 1 diabetes? And there are 5 or 6 sizable intervention studies, not with cardiovascular endpoints, but with just safety and glucose-lowering efficacy results. In type 1, they've recently been published. We had several other in Diabetes Care. We have editorials about it in Diabetes Care and in other endocrine journals. Right now, the FDA is considering whether to approve the drug for use in type 1 diabetes. I don't know how it's going to turn out. The initial advisory panel had a deadlocked 8-8 vote. They couldn't decide what to advise the FDA to do on this. But the two important factoids are that glucose lowering that's attained by adding this class of drugs to basal bolus insulin therapy in type 1 diabetes is about 0.3 or 0.4% A1C. It's real, but small. And so the glycemic benefit isn't very big, and the cost of that in immediate risk is a 3% rate of ketoacidosis in the study population, in the studies, per year. And in general population, in broad populations of people, it's surely going to be higher than 3% per year. And that's not a trivial problem. That's a significant risk in my view. So what we need is more data on who are the highest benefit patients, people maybe with proteinuria, and who are the highest risk patients. Probably people who are not skillful in the use of insulin and inconsistent in filling prescriptions and keeping medical visits and so on. So we need to understand this, and it's a debate in the endocrine world right now. And then finally, how great are other long-term risks with this class of drugs? And the one that I think sort of stands out as an unknown is the risk of metabolic bone disease. There's evidence of increased fractures with at least one of the drugs in this class, canagliflozin. And there are theoretical reasons why there might be metabolic bone risk. For example, calcium, phosphate, magnesium, and other minerals are handled differently by the kidney in the presence of these drugs. But more important, I think, is that the ongoing increased gluconeogenesis, new glucose production by the liver, that occurs, which is part of the main part of the mechanism of action of these drugs, leads to withdrawal of gluconeogenic substrates from lean tissue mass throughout the body, and bone matrix is included. Muscle is the main one, but bone matrix is a significant one. Muscle can be reconstituted later if it's depleted. You cannot restore bone matrix. Bone matrix is gone, it's gone. So there are long-term risks that we don't know. So a lot of questions, incomplete answers. Some of you will, in publications, give us some of the answers, I hope. Now, lifetime strategy from my point of view. Type 2 diabetes in particular, but diabetes in general, is a hugely prevalent illness worldwide. I mean, it's just a monstrous medical problem. The evidence that I just showed you, to me, says we really should be putting more effort into timely diagnosis, not missing 2 or 3 or 4 or 5 years of hyperglycemia while accruing glycated tissues and other tissue injury from the hyperglycemia as complications before treatment is even started. So from the public health point of view, aside from reining in the food manufacturers and having healthier lifestyles, we really ought to be making a diagnosis in a systematic way and not letting people run hyperglycemic unchecked. And once they're diagnosed, they should be treated to aggressive glucose targets, not 7 to 8%. Absolutely not 7 to 8%. They should be treated to near normal when they can be, when it's possible. Metformin is a very safe drug, very inexpensive, very well tolerated, and patients should be started on treatment early on. So that's the middle, I think this is some build here. The middle part of this natural history is where ordinary office-based primary care medicine should be doing a good job controlling glucose to prevent microvascular complications and accruing a favorable as opposed to an unfavorable legacy effect for cardiovascular disease. The A1C target should be 7% or less, as it is now. That's my view, not in contrast to what the ACP was proposing. And then at some point, and 10 years is sort of a round number to pick as the cut point where it begins to be problematic. After 10 years of diabetes, there tends to be accrual of not only advancing age, but also diabetic complications, a little neuropathy, a little microvascular disease generally. And in addition to that, a greater likelihood of cardiovascular disease that's unrelated to diabetes. You know, only half of the heart disease that you see is due to diabetes. Half of it is due to diabetes, but there's another half that isn't. But that is accruing along with whatever diabetic complications are accruing over the passage of time. So after 10 years, it gets harder. Here's where personalization of therapy, the part of the title of my talk, is mandatory. You just can't use algorithms in patients like these. You have to make some decision about what the risks are for that patient, what the potential benefits are, and which kinds of pharmacotherapy and other interventions are going to be appropriate for that patient. And here's where we really need good diabetes centers like that run by Dr. Hirsch here. Not every place has a lot of diabetes experts who help with this. And not every place in the country has good cardiovascular support, as you have here. We need to collaboratively work with these patients and work out individualized plans. A lot of them should be using the GLP-1 SGLT blockers, and some should be using the GLP-1 receptor agonists in this setting. But it's going to be different for each patient, how you make the decision and what the doses are and what other concurrent therapies there are. So we're not done with this yet. This is going to play out in the next few years, and it's going to be very interesting and very exciting, I think, because we now have interventions at all stages of diabetes that really work, that are affordable, that are safe, and we're fundamentally not using them to full advantage yet. Now, the last couple of things I want to say is from ACCORD, which are the patients from the ACCORD data, which was the best data set to get at this, who are the patients who were at risk of more intensive therapy? And the baseline characteristics that fell out of a multivariable analysis are shown here. That is a high starting A1C, which is a surrogate for advanced physiologic difficulty in controlling glucose, and also sort of general burden of tissue injury. Presence of neuropathy, so that's a surrogate for microvascular disease, and aspirin prescription, at that time widely used for secondary intervention in diabetes for cardiovascular protection. And so that's a surrogate for suspected, if not known, cardiovascular disease. So that's not very helpful. We sort of know that those things are reasons for concern. But I want to add to that the idea that there are behavioral factors or physiologic factors that we don't know how to recognize just by baseline characteristics in an office evaluation or enrollment in a study that play in here. And so this population of people in the intensive arm of ACCORD who started off with A1Cs that were maybe 8% or 8.5%, and who were trying to get below, down to 6 actually, and couldn't get below 7 in the first 6 months to 12 months. That's the at-risk population. And you cannot identify them all with ordinary risk factors. You have to try it and see. And so there is a trial of therapy identifying behaviorally impaired or physiologically difficult individual cases. So that's another piece of the personalization. So in response to the ACP's argument that you should never go below 7%, I would say if you don't have obvious severe risk factors for lower glucose, and the A1C is 7.9, give it a try, see what happens. Use one of the standard therapies. They may get down to 6.5 and be great. If they don't, then that's a bad signal and you don't persevere. So that's my wisdom. This is just a summary of that statement. There are risk factors such as duration and presence of complications, and then the behavioral failure to improve using standard treatments. So we need to do more screening. We need to do better primary care, sort of algorithm-driven glucose control, seeking good targets in patients who are easy to control. And then, and this is where you come in, once patients get farther down the road and have heart disease, we've got great tools to use, and we better learn how to use them more efficiently than we know now. We're just beginning to learn. Thank you very much for your attention.
Do we have a hand mic that goes around or not? So please state your questions loudly. Matt, you went back to the Origin trial, which is a very interesting study. A lot of people would say it's a null trial. It goes in the round file. But there were two incredibly important findings from that trial. One was the one that you started off with, no increase in cardiovascular events at all, flat. But there was, and I think there still is, a prevailing story that it is associated with cancer. And most of the big data set, most of the studies that are being published now are from big data sets. They are not from trials. Maybe you'd like to comment on that.
Well, the first thing is if you have a 12,000 patient randomized clinical trial with 5 years duration and good ascertainment of outcomes, I'll take that over 20 epidemiologic analyses. I mean, it's really better data than comes from any epidemiologic analysis. The other thing, though, is that in big epidemiologic studies, you get a mixed bag of interventions. So insulin is not just insulin. Insulin is basal insulin, it's premixed insulin, it's rapid-acting insulin, basal bolus therapy in some patients. And if you have to look for a danger signal in the insulin epidemiologic analyses, it's associated with rapid-acting insulin. Temporally, it was the introduction and titration of rapid insulin that coincided time-wise with the increased cardiovascular mortality in ACCORD. In a very sophisticated statistical analysis, post-hoc epidemiologic analysis that we did of ACCORD data, we found the same thing. That is, insulin dose and insulin exposure over time did not correlate overall with cardiovascular risk. Basal insulin showed no correlation with cardiovascular risk. There was a weak residual effect, not statistically significant, for prandial insulin use. So I think that the concern that remains has to do with prandial insulin. And so I'm very interested in alternatives to prandial insulin for mealtime glucose control.
Other questions, please.
We're all familiar with the peripheral neuropathy in diabetes. I don't know that there's so much information in the literature on autonomic nervous system in diabetes. Do you have any information on the epidemiology of that affect autonomic nervous system?
Right. ACCORD is one of the trials where very careful autonomic nerve function tests were done. There's a lot of autonomic neuropathy in the 15-year duration patients that were recruited into ACCORD. No, I was 12-year duration, anyway, long duration. And there was quite a strong correlation between the presence of cardiac autonomic neuropathy and cardiovascular risk. It was, it's one of the factors that correlates. It was not done the sophisticated tests were not done in the whole population, and so it's hard to be sure what that means in terms of the elevated death rate. But it's clearly a predictor of harm, at least in a subpopulation of ACCORD. There's a nice paper on this by Radhika Pop-Basui, that's the first author. I think it's one of the unstudied aspects of diabetic complications. We don't have very good objective measures for either peripheral neuropathy or autonomic neuropathy that can be done easily in a clinical setting. So you raise an important point, and that's all I know.
Earl.
So Matt, quick question and a comment. The question is, you did mention the amputation risk from cannabis, and I wonder if you can tell us your views on amputation. The comment is that I would say for the last 25 years, a week doesn't go by and somebody doesn't come into our clinic from the community, from another clinic within our system, that is diagnosed with type 2 diabetes, but they actually have type 1 on insulin or not. And my concern, as we use more and more of these SGLT2 inhibitors, we are going to see an explosion of DKA because we're not diagnosing it. 50% of these type 1s are diagnosed as adults now. We don't know why. But I'm just very concerned that this is going to become a huge public health problem.
Yeah, so about the amputation risk, usually just toes, distal lower extremity amputations, which were increased in the canonical flows and development program, not in the other GLP-1, not in the other SGLT blocker programs. The hypothesis that everybody assumes is the best one to explain that would be hemoconcentration. Hemoconcentration with increased viscosity of blood, higher red blood cell volume per volume. Also correlates with increased stroke rate, and there's a modestly increased hazard ratio of strokes in some of the trials. So I don't know how that's going to play out long term. It's quite possible that with bigger numbers and longer exposure, we're going to see more amputations and more strokes associated with the use of these drugs. That's plausible. And once again, it just underscores the idea that we're going to need to learn how to assess which patients are going to get the most benefit and which ones have the highest risk. And balance those in making the decision. About late onset type 1 diabetes, Earl is absolutely right that 50% of people with autoimmune mediated type 1 diabetes have onset below age 20, and 50% are diagnosed after that, and they get mixed into the type 2 population. And so if broad population guidelines for intervention consider all the patients who get diabetes when they're grown-ups to have type 2 diabetes, they're going to be treating those patients incorrectly. That's one of the reasons why back in the days when I was doing a lot of in-hospital teaching to our trainees, and I wanted to show them people who had terrific diabetic complications, so I could show palmar fascial thickening and distal neuropathy and so on. I would go and ask the nurse, do you have anybody with bad complications? And we would find the patient. That was always a patient who had late onset type 1 diabetes, just about. So they got treated with oral agents when they should have been on insulin from the start. And patients like that should not be treated with SGLT blockers without very careful attention to insulin dosing and protection against ketoacidosis, because it can be fatal. It's not a trivial complication. I share your concern.
Excuse me, one final question? Yes, sir.
So I'm really glad you brought up the exercise and education elements of being more aware of diabetes and stuff before. But I mean, I would almost argue that like exercise is like a therapeutic strategy that you could use beyond the pharmacological. So like, I guess there's other trials being done on that, and two, like, should that be more of the narrative, like part more of the narrative?
So physical activity as an intervention?
Yes.
Is that your point? Yeah, I agree. So let me start it the other way around. Population, on a population basis globally, there's an explosion of obesity and diabetes going with obesity. And it's driven by 2 or 3 factors. One of them is increasing wealth and supply of enough food. The second is a shift to an unhealthy food choice, processed foods, and going away from unprocessed foods that had been traditionally used for years during when we were evolving from monkeys. And then physical activity changes. So there's strong evidence that we would be better off if we had more physical activity. I think it mainly is a treatment for prevention of diabetes, not treatment of diabetes.
Do you think we're too sick at that point?
Sorry?
Do you think we're too sick at that point, and or like compliance issues?
I'm just going from data. When you implement intensive exercise as a therapy for type 2 diabetes, you get almost no A1C lowering, no blood pressure lowering. It's very ineffective. And if a person is taking insulin, then you increase the hypoglycemia risk rather than reducing it. So the time where you get the most bang for the buck from working on physical activity and exercise interventions is in people who are at risk for diabetes who don't yet have it, in my opinion. Not that it's wrong if you have diabetes, it's good. It just don't count on it to solve the problem.
So let me take this opportunity to thank Matt for a wonderful 2 days here. You certainly did your business, and it was our great pleasure and honor to have you here, Matt. So thank you very much.